Hi, everyone. Welcome back. I hope you all had a nice lunch and good discussion during the breakout session. For those interested in continuing the conversation, we will be having a social hour at the end of the day as well. So there will be more chance to connect. My name is Ken Sutha. I use he, him pronouns. I'm an Asian American male. I'm bald. I'm wearing a bluish shirt with some tigers on it with a background of flowering trees blooming in the courtyard of our Lucile Packard Children's Hospital. I serve as co-chair of SMATI along with Dr. Poulos, and I'm an instructor in pediatric nephrology here at Stanford, in which role I see patients and do lab research. I also have the lived experience of 30 years with living with chronic kidney disease, including 2 transplants and being on dialysis for a number of years during my residency and fellowship. It's my distinct pleasure to introduce our next speaker for session 4, Andres Gallegos, who will be presenting A Voice for Health Equity. During the session, he will overview the National Council on Disability, NCD, and its role as federal voice for persons with disabilities to the president, his administration, Congress, and to federal agencies, and its efforts to achieve health equity for persons with disabilities by advising on all matters affecting persons with disabilities in the country and the US territories. NCD's health equity framework will be discussed with a focus on its 4 core components. Andres Gallegos, Esquire, is a disability rights attorney and shareholder in the Chicago, Illinois law firm of Robbins DeMonte Limited. Andres founded and directs his law firm's national disability rights practice, which has as its focus improving access to healthcare and wellness programs for persons across all categories of disabilities throughout the country. In February of 2018, Andres received a congressional appointment to the National Council on Disability. And in January 2021, on the afternoon of his inauguration, President Biden designated Andres to be the chairman of the NCD. Additionally, Andres has been recognized for his work in disability advocacy as recipient of the American Association of People with Disabilities 2015 Paul G. Hearn Leadership Award. Andres has a deep history of advocating for the rights of persons with disabilities, having been appointed by the Illinois governor to the statewide Independent Living Council of Illinois, serving 2 terms, is the immediate past chairman of the board of directors of Access Living of Metropolitan Chicago, Chicago's Center for Independent Living, and has been on its board for the past 11 years. And he was recently voted to the board of directors of Disability Lead, which has as its mission to increase civic engagement and diverse leadership by developing and building a network of leaders with disabilities, consistent with the spirit of the Americans with Disabilities Act. Andres is a person with a disability, having sustained a spinal cord injury, resulting in quadriplegia, as a result of an automobile accident in 1996. Andres is also a veteran of the United States Air Force, having served honorably for 14 years. And with that, I hand it over to you.
Ken, thank you so very much. It's an absolute pleasure to be able to share with you the work of the National Council on Disability, a federal agency with a deep history as the federal voice for people of all categories of disabilities, not only in this country, but in our territories as well. And as a federal voice for inclusive and accessible health to address the significant health disparities that exist between people with disabilities and our non-disabled counterparts. Now I say while it's obvious I am a person with gray hair, what may not translate through the video is that I am a person with a disability, class of 1996, when I sustained a spinal cord injury in a horrific automobile accident resulting in quadriplegia, C5 and C6. The National Council on Disability is the independent federal agency that's charged with advising the president, the administration, Congress, and federal partners on all aspects of federal disability policy. I've been a member of the council since 2018, when I was congressionally appointed by Senator Chuck Schumer. And then on the afternoon of his inauguration, President Biden appointed me as its chair. The council has a rich history as being the federal voice for people with disabilities. The history of NCD dates back to 1972, when Congress proposed an Office of the Handicap as part of the Rehabilitation Act. Its purpose would be to review programs of the Rehabilitation Service Administration and to evaluate and coordinate all programs affecting persons with Disabilities. But Congress eliminated the office shortly after it was created. The idea resurfaced in May 1977 when delegates from every state gathered at the White House Conference on Handicapped Individuals. The participants reviewed federal disability policy and offered legislative recommendations. Among their conclusions was that the incoherence and intrinsic tensions of various disability policies required an agency to bring it to order. Thus, NCD was first established as a small advisory council within the Department of Education in 1978, and we transformed into an independent agency in 1984. And we were charged with reviewing all federal disability programs and policies. What you see on the screen are two photos of cover pages of two seminal reports that the National Council on Disability authored in 1986 and 1988, Towards Independence and On the Threshold of Independence. In 1986, the Council conducted a critical examination of over 40 disability policies and programs at the federal level. But we critically examined 10 topics: equal opportunity laws, employment, disincentives to work under Social Security laws, prevention of disabilities, transportation, housing, community-based services for independent living, educating children with disabilities, personal assistance services, and coordination of disability policies and programs, with the aim of making recommendations to the president for prioritizing the advancement of equal opportunity laws for people with disabilities. The results were published in NCD's Towards Independence report. 2 years later, NCD published a follow-up report that evaluated progress made since its 1986 report, Towards Independence, on each of those 10 topics, setting the foundation for NCD to draft the first version of the Americans with Disabilities Act. On the screen, what you see on this slide is copies of the initial pages of both a Senate resolution, a bill, and also a congressional bill with the first draft of the Americans with Disabilities Act as authored by the National Council on Disability. In 1986, NCD recommended the enactment of the Americans with Disabilities Act and then drafted the first version of the bill introduced in the House and Senate, as you see here, in 1988. The passage of the ADA was not guaranteed. We had to fight for it, mobilizing the able and disabled to use forms of civil disobedience and protest to generate support for its passage. At 10 a.m. on 26 July 1990, President George H.W. Bush signed into law the Americans with Disabilities Act on the south lawn of the White House in front of approximately 3,000 able and disabled people. Noting that a year earlier, the Berlin Wall came tumbling down, the president, as he signed the ADA, said, "Let the shameful wall of exclusion finally come tumbling down." The promise of equal opportunity, full participation, independent living, and economic self-sufficiency for the then approximately 43 million people with disabilities in the United States was cemented in writing. Its intent was to level the playing field for persons with disabilities who were ignored in all of the previous legislation securing civil rights for Americans. As a testament to the influence of the National Council on Disability as a federal voice for people with disabilities, NCD Chairwoman Sandy Perino and Councilmember Justin Dart accompanied the president on the stage for this historic signing. Today, our mission is to advise the president, his or her administration, Congress, and federal agencies on all policy matters affecting people with disabilities in the country and in our territories. We are by far the smallest federal independent agency in all of government. The council is bipartisan. We consist of 9 council members, 5 are appointed by the president, and 1 each from the minority and majority leaders of the House and the Senate. The president appoints the chairman. Each council member is appointed for an initial 3-year term with an opportunity to serve for a second 3-year term. The chairman appoints the executive director. And we are fortunate and blessed to have Ann Summers McIntosh as our current executive director. Anne was National Council on Disabilities Director of Legislative Affairs for approximately 10 years prior to accepting my ask to serve as our executive director. We serve as the federal voice of people with disabilities, and we render advice in 14 policy categories, which includes those that you see here. And what you see on this slide is a splash page of the National Council on Disabilities website that shows the different policy areas in which we provide advice. For example, advocating for the ratification of the United Nations Convention on the Rights of People with Disabilities, the topic of civil rights, cultural diversity, education, employment, healthcare, housing, long-term services and supports, technology, transportation, among other topics. You can find us at ncd.gov. We commission reports that are data-driven and research-driven. We meet with representatives of the community that assist us in formulating policy recommendations. While all of the categories of issues are important, in my estimation, none is more important than healthcare. Now that's true not just because of where we are today, but that's been historically true. The National Council on Disability has long held the view that attaining and maintaining good health is critically important for everyone, but more so for people with disabilities. It is truly the predicate to our ability to live, our ability to learn, and our ability to work and earn. Without obtaining and maintaining good health, our advocacy for inclusion and accessibility in education, in housing, in transportation, etc., is for naught. That's why we must serve as a federal voice for inclusive and accessible healthcare. On this slide, you see a photo of a virus molecule. We have served as a voice throughout the pandemic. As you know, people with disabilities have been disproportionately affected by the COVID-19 virus. And that's particularly true for people with IDD, intellectual and developmental disabilities, as well as those with underlying health conditions, like, for example, chronic lung disease, diabetes, chronic kidney disease, and serious heart conditions or weakened immune system that place them at risk for contracting the virus, higher risk for hospitalization once the virus is contracted, and with a greater risk of dying from the virus. As the number of cases mounted and hospitals were overwhelmed, many states and healthcare systems implemented previously developed medical scarce resource allocation or rationing policies, commonly known as crisis standards of care. Those policies set forth triage criteria for healthcare providers, criteria to assess who would and who would not receive care, or used to determine priority of care. More often than not, those policies discriminated against people with disabilities. That discrimination was solely based on the mere existence of a disability. In March and April of 2020, disability rights advocacy groups and people with disabilities filed complaints with the Department of Health and Human Services, Office of Civil Rights. Those complaints alleged that guidelines put forth in states like Alabama, Kansas, New York, Pennsylvania, Tennessee, Utah, and Washington illegally discriminated against people with disabilities. The crux of complaints by disability rights advocates were that policies that based triage decisions on quality of life judgments or policies that exclude patients with specific conditions are discriminatory. For instance, Alabama's now rescinded guidelines called for hospitals to withhold ventilators from patients with, quote, severe or profound mental retardation. Those were their words. And that withheld ventilators from those with moderate or to severe dementia. NCD called upon the Director of Office of Civil Rights for Department of Health and Human Services to issue immediate industry guidelines to remind healthcare systems and hospitals that the federal non-discrimination laws apply during times of a pandemic. Now think about that for a moment. Guidelines had to be issued by the federal government to hospitals and healthcare systems throughout the country. Guidelines reminding them that their federal non-discrimination mandates still apply during this public health emergency. What does that say about us? Of course they apply. They especially apply during times of a healthcare crisis. In addition, we urged the Senate leadership to provide funding in the COVID relief package for home and community-based services, funding to assist people to transition out of congregate living settings, funding to assist families who must stay at home to provide care for adult children with disabilities, and ensuring the availability of protective personal equipment for family and professional caregivers of people with disabilities. And when the National Academies of Science, Engineering, and Medicine issued its COVID-19 framework, people with disabilities were again forgotten. We spoke out. We informed the Academy that any discussion of equity in the care and treatment and vaccination of America must include people with disabilities. On this slide, you see another photograph of a virus molecule. In December 2020, there was no federal guidance on the safe and equitable allocation of vaccines. Each state was developing its own distribution guidelines. As no federal guidance would be forthcoming, NCD called upon state governments and health departments to determine effective and equitable frameworks. All state vaccine allocation frameworks should explicitly include individuals with intellectual and developmental disabilities, direct support professionals, and family members who provide support to them. While there was a scarcity of surveillance data, there was sufficient data to establish unequivocally that people with IBD were among the most severely affected by the virus in every jurisdiction. To not then prioritize them for purposes of the vaccine was simply unconscionable. In addition, the frameworks must also include people with disabilities that had comorbidities that place them at a particular risk for contracting the virus and at risk for greater negative outcomes. Even before the new administration was settled, NCD wrote the president-elect and our congressional leaders. We reminded them that tens of thousands of lives of people with disabilities were still at risk because their needs have not been addressed in any of the COVID-19 relief legislation to date. We urged their inclusion in subsequent legislation. In February, we wrote the president and informed him, without exaggeration, the lives of people with disabilities hang in the balance because their needs have not been addressed in any of the COVID-19 relief legislation to date. Now, prior to the pandemic, the National Council on Disability has been a federal voice for inclusive health. On this slide, you see a series of cover pages of our various reports that we've issued over the years. For instance, in our 2017 issues brief, Neglected for Too Long, Dental Care for People with IDD, we examined the lack of dental care many people with IDD continue to experience, due in part to a shortage of properly trained dental care providers. The brief examined the American Dental Association's Principles of Ethics and Code of Professional Conduct. It surveyed dental training and dental school curricula requirements. It provided examples of programs that do train dental students in the care of patients with IDD. The report also explored the impact of Medicaid on the issue and discussed the concept of medically underserved populations. The issue brief concluded with recommendations to federal and state policymakers, the Commission on Dental Accreditation, and the American Dental Association. In January 2018, we asked the president of the American Dental Association to revise its current principles of ethics and code of professional responsibility, revise them to better reflect the rights of people with disabilities. In response, the association did so on October 22, 2018. The ADA code now dictates that a dental care provider may not deny care to a patient based on the patient's disability, and that any provider in need of another skill, knowledge, equipment, or expertise has an obligation to consult with or refer that patient with a disability to that provider. In 2018, we also addressed the same issue with the Commission on Dental Accreditation. We encouraged the Commission to revise its curricular standards to require that students learn and train in the treatment, management of patients with intellectual and developmental disabilities. And in our March 2018 report, Beyond Guardianship, we looked at guardianship affecting 1.3 million people. We undertook a report to examine the treatment of people with disabilities within the legal system that establishes guardianship, to examine the use of alternatives to guardianship, such as supported decision-making, and to make recommendations that will help align the use of guardianship and decision-making alternatives with the Americans with Disabilities Act, with a particular focus on the integration mandate. Again, a series of cover pages of our various reports. Beginning in 2019, as part of our bioethics series reports, we had a number of reports that I'm going to mention now. The overarching theme was to address the continuing devaluation of the lives of people with disabilities in medical decision-making. Negative biases and inaccurate assumptions about the quality of life of a person with disability are pervasive in the United States society. Those biases and incorrect assumptions result in the devaluation and the disparate treatment of people with disabilities. And in a medical context, these biases and assumptions can and do have serious and even deadly consequences. In this series of reports, we explored how people with disabilities are impacted by biases and assumptions in some of the most critical healthcare issues we face, including organ transplantation. People with disabilities are often denied equal access to organ transplants solely on the basis of their disability. This report examined the reasons for this and its impact. Additionally, the report explored how people with disabilities and their families can be pressured into organ donation. Physician-assisted suicide. This report provided an update to our previous analysis of state laws supporting physician-assisted suicide and examined the ineffectiveness of purported safeguards. Genetic testing. In this report, we examined the range of scientific, commercial, professional, and social factors that converge around prenatal genetic testing and their effect on the lives of people with disabilities. The report also provides an update on the interaction between genetic testing and employment discrimination. On this slide, again, you see cover pages of a series of 3 reports that we issued. Continuing with our bioethics series, quality adjusted life years. Here we took a critical examination of the use of QALYs by insurance programs, including Medicaid, to determine the value of treatment and how the use of QALYs impacts people with disabilities and their access to care. We also released a report on medical futility. Healthcare providers' subjective judgments about whether a patient's life is worth living often influences their decisions regarding whether to withdraw or withhold medical care. How physicians see us is how they treat us. This report examined multiple perspectives on medical futility decisions relating to people with disabilities. It analyzed how state and federal laws can be strengthened to prevent disability bias from impacting critical healthcare decisions. In 2010, the Patient Protection and Affordable Care Act required the United States Access Board to develop standards for accessible medical diagnostic equipment. The act also recognized the absence of accessible medical diagnostic equipment as a barrier to people with mobility disabilities in our ability to obtain thorough examinations and treatments. That was and still is systemic and pervasive in just about every healthcare setting. While the mandate was for those standards to be completed in 2014, given the enormity of the undertaking, the Access Board released its standards in 2017. The standards are merely voluntary until adopted by a federal agency of jurisdiction. However, the Department of Veterans Affairs voluntarily adopted those standards and acquired accessible medical diagnostic equipment. That, however, was an anomaly. Healthcare systems throughout the country have not voluntarily adopted the use of accessible medical diagnostic equipment. In early 2017, the Department of Justice proposed to adopt those standards, and it issued an advance notice of proposed rulemaking. However, in December 2017, the Department of Justice withdrew that notice, expressing that it wanted to determine if the regulations were in fact still needed. As a result, we undertook a report on accessible medical diagnostic equipment, which we unveiled just last year. The report highlights the continuing need for accessible medical diagnostic equipment, as people with mobility disabilities who utilize mobility devices are still being discriminated against receiving less than thorough examinations and treatments than those provided to patients who are not disabled. Our weight is hardly ever captured. We are consistently examined while we remain in our wheelchairs, even when it's clinically inappropriate to do so. Our report urges the Department of Justice and Departments of Health and Human Services, Office of Civil Rights, to promulgate regulations adopting these critically needed standards and adopting scoping requirements. On this slide, again, 2 photos of cover pages of our last 2 reports. In October 2021, we conducted a thorough examination of the impact of COVID-19 pandemic on people with disabilities. Here, we're looking at the impact of the pandemic on people across all categories of disability. In the areas of disability discrimination in healthcare, the devastating impact of COVID-19 on people with disabilities in congregate care facilities, the impact on the direct care workforce, how the pandemic affected students with disabilities, employment of people with disabilities before and after the pandemic, how people who are deaf and hard of hearing are affected by the pandemic, and the effect the pandemic has had on the mental health of people with disabilities. Last month, we unveiled the report examining Medicaid reimbursement rates for oral health care for people with IDD. As you know, compared with other populations, adults, adolescents, and children with IDD experience poorer health and more difficulty in finding, getting to, and paying for appropriate health care. This disparity has made people with IDD more likely to have poor oral hygiene, periodontal disease, and untreated dental care in greater percentages than members of the general population. This disparity is created in part by insufficient Medicaid oral health reimbursement rates for people with IDD. In February of last year, I issued my vision and priority statement during my tenure as chairman. Given the times that we live in, our abiding focus has to be on healthcare, foremost all things COVID, and addressing accessibility barriers to healthcare for people across all categories of disabilities, and addressing the social determinants of health, the factors historically underlying the extensive health disparities between people with disabilities and our non-disabled counterparts, as well as health equity. While the focus on healthcare will be our abiding focus, we will continue to work to eliminate sub-minimum wage for persons with intellectual and developmental disabilities, and for persons with significant disabilities and who are blind, as well as addressing other issues to improve the lives of people with disabilities, those who care for them, and those who love them. On February 14, we released our health equity framework for people with disabilities. Now, there are 39 specific components to our framework proposal and counting. We formed a health equity subcommittee internally within the council and have been meeting weekly over the last year to develop the framework. Given how much we already know about the need, it seemed appropriate to keep our focus on what to do about it rather than just revisit the evidentiary base. We met with several national disability advocacy organizations to learn of their members' healthcare priorities. Their input was key in the development of the framework. We then assembled a dream team, 14 people who have dedicated their professional lives researching health disparities between us and our non-disabled counterparts, health equity for people with disabilities, and ableism in healthcare. We had a couple of virtual meetings with the dream team. We presented our rough framework outline and asked them to critique it and to identify any gaps. We also had a couple of meetings with Domestic Policy Council to inform them of our intent to develop the framework and reviewed its initial rough outline. And over the last 6 months or so, we met with various Hill offices that have jurisdictional authority over certain components of the framework, as well as many federal partners that we identified as offices of primary responsibility for the framework's components. Certain members of our dream team participated in some of those meetings with us. Now, we know that the framework with all of its components is a lot to digest. So we posed to our dream team that if we could only press hard and accomplish a few things initially, what would those be most important to start with. And unequivocally, there was broad consensus that the elements that we've noted as our four foundational elements, our core elements, were the ones that would set others into motion, that they would be game changers if we could get them. And those four foundational components are, as you see here, designation of people with disabilities as especially medically underserved population, accessible medical diagnostic equipment, improving data collection concerning healthcare for people with disabilities across the lifespan, and comprehensive disability clinical care curricula. To achieve health equity for people with disabilities, it is critical that people with disabilities be legally identified as a special medically underserved population under the Public Health Service Act and gain the benefits associated with that designation. These benefits include, among other things, federal funding for health centers and public health infrastructure, like federally qualified health centers, eligibility to apply for federal funding to develop and operate community health centers, access to loan repayment and training programs in the Health Resource Services Administration workforce development and training programs, including the National Health Service Corps scholarships, incentives for physicians to treat the designated population in the form of higher Medicare and Medicaid reimbursement rates for physician services, and preference given to research at federal agencies, including the National Institutes of Health that studies medically underserved populations. Usually, medically underserved population designations by the Health Resources Service Administration require population groupings based on geography, which is not applicable way to providing equitable healthcare to the national community of people with disabilities. So as a way of bypassing that requirement, people with disabilities must be designated by Congress as a special medically underserved population through a revision of Section 330 of the Public Health Service Act. In addition to the special medically underserved population designation, is the designation of people with disabilities as the health disparities population under the Minority Health and Health Disparities Research and Education Act of 2000. Under that act, the director of the National Institute on Minority Health and Health Disparities, after consulting with the director of the Agency for Healthcare Research and Quality, may designate a population as a health disparity population if there is a significant disparity in the overall rate of disease incidence, prevalence, morbidity, mortality, or survival rates in the population as compared to the health status of the general population, which is certainly the case for people with disabilities. Designations for health disparities population are as you see here. It establishes a center of excellence in research and training, loan repayment incentive up to $35,000 for every year that a physician dedicates themselves to the care and research of health disparities for people with disabilities. Health disparities research as a priority by AHRQ, data collection for National Academy of Sciences, and health professions education on reducing health disparities and provisions of cultural health care for people across all categories of disabilities. Another core component, the accessible medical diagnostic equipment. Here we're looking for Department of Justice and Department of Health and Human Services, Office of Civil Rights to adopt as binding regulations the use of accessible medical diagnostic equipment. Standards for accessible medical diagnostic equipment that were developed, as I mentioned before, by the Access Board in 2017, pursuant to its mandate under the Affordable Care Act. These standards that provide for height adjustable examination tables, examination chairs, and diagnostic equipment such as X-ray machines, MRI equipment, and many others. It's particularly critical for those of us with mobility disabilities that can't independently transfer onto examination tables, examination chairs, or diagnostic equipment. And for those of us who cannot independently transfer, our lived experience is that we get examined or treated while remaining in our wheelchairs if we get examined at all. The third core component, Data matters because we matter. Improving data collection is a vital part of achieving health equity for people with disabilities. With due consideration of privacy concerns, it's necessary that indicators of disability status be included in all public health surveillance systems. This must be done to assess the impact of public health threats and events on populations with disabilities, so that effectiveness of planning and response can be assessed and improved upon. This data should be captured across individuals' lifespans and be inclusive of all ages and times of onset of disability. Healthcare organizations must also collect and report and record patients' data disability status and needed accommodations within electronic health records to plan and provide informed quality healthcare. Uniform disability identifiers must be included in electronic health records, death certificates, and insurance claims captured for all patients, even if treatment sought is unrelated to a person's disability. Part of the lack of sufficient data concerning people with disabilities is the information gap overlooked by government agencies. Standardized disability identifiers are necessary across federal surveys. And our last core component. There's been an abundant number of studies that demonstrate that the overwhelming majority of medical school graduates do not feel confident in their knowledge and skills to treat patients with disabilities. The research also shows that they want to and would like to. This points to a lack of formal training, exposure, and clinical experience in training, not just in medical school, but in graduate residency training programs in all 24 medical specialties. Clearly, there's a need for a standardized national core curriculum that at the earliest opportunity introduces the students to the skills needed to effectively communicate, understand, appreciate, treat, and even advocate for their patients with disabilities. I dare say that everyone, including patients with disabilities, without disabilities would benefit because those skills can be used to treat everyone. And if it translates into care that embraces more respect, dignity, humanity, and support for everyone, that's a win-win situation. We have experts with experience to create such curricula. In fact, we already have pockets of progressive medical schools that have already adopted this training. The curriculum has to be comprehensive, meaning that it has to include all aspects of medical care, and this truly has to be interdisciplinary, but it has to be mandated. It's too important and long overdue to leave it to the whims of medical curriculum committees that have dropped the ball in this area for over 20 years. We also have to have questions related to care of patients with disabilities appear on national certifying exams to emphasize that the profession sees this as mandatory and not as an elective. All of this can be implemented, and shame on us if we can't do it on our watch. Applicable to undergraduate and graduate healthcare professional and allied health professional programs, residency and fellowship programs, as well as international schools participating in our federal school loan programs. Now, the core component of our clinical care curriculum it's applicable for schools that we'd like model curricula developed to be used by schools without the capacity to develop their own. They can simply take the curricula that's developed and implement it. And for those who do have capacity, we'd like them to address 8 specific competencies. The first 6 competencies are those that were developed by the Alliance for Disability Health Education in partnership with the Ohio Disability and Health Program, core competencies on disability for healthcare education at The Ohio State University. Those core competencies are that you see here. The first one is contextual and conceptual framework on disability. Second, professionalism and patient-centered care. Third, legal obligations and responsibilities for caring for patients with disabilities. The fourth competency, teams and systems-based practice. The fifth competency, clinical assessment. And the sixth competency, clinical care over the lifespan and during transitions. And the last 2 competencies that the NCD has added is effective communication. Although implied in the foregoing 6, we believe it requires a competency of its own, and then 8 for advocacy. Advocacy is incredibly critical for people with disabilities. And as discussed in the session right before lunch, we've seen how medical providers have to be advocates for people with disabilities to obtain durable medical equipment, complex rehabilitation technology, basic access to paratransit services, and then oftentimes for housing and in other areas as well. The words of Dr. Martin Luther King. As said 56 years ago, they still remain true today. Of all forms of inequality, injustice in healthcare is the most shocking and the most inhumane. We have the ability to make significant change to improve the lives of people with disabilities. And we intend to do that at the National Council of Disability by advocating for health equity and implementing the plan and framework that we put in place to make sure that it makes a difference, a meaningful difference in the lives of our community. Thank you. And with that, I will take your questions.
Thank you so much, Chairman Gallegos, for that fantastic presentation. Really covered so much material, and it's really awe-inspiring to see all of the work that the NCD has done and that you have done, that you spearheaded for health equity for individuals with disabilities through the pandemic, and durable or accessible medical equipment, and all these bioethics related issues related to disability and healthcare. We have a couple questions from the chat that I'd like to bring up. Let's see. So what role do you see the recruitment of more people with disabilities into healthcare professions how do you see that as being important to the NCD's goals for achieving health equity?
So it's critically important, right? And as part of our framework, as I mentioned, we're looking for the health disparities population designation. And the reason for that is because it provides incentives for people with disabilities to get involved in research, right? But we need greater incentives for more people with disabilities, not only to get to be enrolled and become doctors and get involved in the healthcare professions, but also people with disabilities in public health, people with disabilities in healthcare administration. And we need that core curricula that we talked about, the clinical care curricula, to be included there as well, because we need our administrators to know what the issues are affecting people with disabilities. But beyond that, we need people with disabilities within healthcare systems, leadership teams, and we certainly need representations on boards, healthcare systems boards of directors. People with disabilities need to be at the table where decisions are being made about the care that's being provided in the community.
Great, thank you. Another question from the chat. How does your latest publication related to the health equity framework address individuals with hidden disabilities, including mental health conditions? It's
a part of our framework. As I mentioned, there's 39 discrete components of the framework, and mental health is certainly part of it. Ensuring that there's adequate mental health services that are being provided. One of the things that we need to address within the mental health space is ensuring that mental health providers, mental health facilities, and behavioral health units will accept patients that have physical disabilities that may need some assistance with activities of daily living. The dirty secret is that what we found is that these facilities and these units have exclusionary criteria, and that if somebody needs something, other assistance beyond simply mental health services, while they may be qualified for those services, they're often denied admission because the facility just doesn't want to care for them. And so as a result, emergency rooms have become the de facto treatment for people for mental care, for the mental health services being provided for people with physical disabilities, and that has to end.
Thank you. Another question. Do you have recommendations on how best to advocate for adherence to the NCD guidelines for health systems we work for? Do you foresee these guidelines becoming incorporated into CMS or JCAHO requirements as a means to make change?
So if you look at our framework, each component has at the end a designation of what's required to implement it. It's going to take a combination of some administrative action by federal agencies. It's going to take some congressional action by legislation, and others we're hoping will be enacted by way of executive action by the president and the administration. And so individuals that want to support our framework as we continue to develop the framework and refine it, we're also meeting with legislative offices and federal agencies, having in-depth and meaningful conversations to translate these recommendations, this blueprint that we laid out for our federal partners into legislation, into regulations, into guidance, and into policy, whether that's issued by CMS or any other agency that has jurisdiction over them.
And similarly, in terms of the education component that you talked about at the end, what ways do you see in ensuring that gets implemented? Because oftentimes we see that there are these many competing demands on the time of healthcare students, and trying to gain priority in what gets included in the curriculum can often be difficult. What do you foresee as the way to kind of put I guess teeth behind this and ensure that it's something that it's prioritized?
Yeah, a great question. As I mentioned, the curriculum not only has to be developed, but it has to be mandated, right? So it's not viewed simply as being an elective. So the legislative framework for the curricula is in the Affordable Care Act, Section 5307, and that allows the Secretary of Health and Human Services to grant funding for the development of the curricula. But the legislation doesn't say it has to be mandated and that it has to be used once it's disseminated to the various medical schools. And so we're looking for Congress to amend 5307 to ensure that it is mandated, that once curricula is developed, that it has to be part of the training that's provided to medical students.
Great, thank you so much. It always confuses me, like thinking about all the different levels of federal regulations and when there's recommendations of things, but then how does it actually get implemented? So your perspective of kind of seeing from the other side is really helpful for us, as we don't often think about that legislative component and the administrative component.
I'm not a fan of a lot of federal regulations, but in some areas it's needed. And this is one particular area where I believe it is needed.
And then you did discuss a little bit about the general makeup of the NCD and how they're appointed. One of our earlier talks by Alice Wong addressed a discussion about disability justice and making sure that we're incorporating perspectives different from what have been historically centered, those of white cis males. What ways does the NCD incorporate disability justice into the way that it's building things? I know you obviously called out some of these things within the health equity framework, but how do you see the NCD prioritizing that?
Well, look, disability justice is part and parcel of everything that we do, right? We look at the lens of where are people with disabilities historically and systemically being discriminated against, whether it's housing, education, transportation, you pick a category and we're at the bottom if we're included at all. So all our programs look to ensure that people with disabilities are included in every aspect of our society and receive the care and support that they need, particularly in the area of healthcare, right? And as I mentioned, this truly is the most important issue that we have to address for people with disabilities, because we can't engage in all aspects of society as we're intended to when under the spirit of the Americans with Disabilities Act, if we don't have our basic access to health and attain and able to maintain good health. So we can engage in employment and education and recreational activities in a manner in which we want to, if that health isn't provided to us.
Yeah, as we had discussed in some of the earlier sessions, many of these things are so intertwined, and trying to get a better understanding of how to fix these systemic issues and how ableism is kind of ingrained in so many things is a huge thing. But obviously the NCD is doing tremendous work in trying to tackle this and bring this to people's attention. Another couple questions. Somebody asked, are there any reports dedicated specifically to challenges of physicians and other healthcare workers with disabilities? If not, are there plans to address that? We of course understand that understanding patient experiences and addressing health equity is very important, but having a diverse workforce that includes doctors with disabilities and other healthcare workers is important to achieving this as well. I think you did address this a little bit in the earlier question.
Yeah, and so we don't have a to date, we don't have a specific report that focuses upon that, but that's something certainly that we may be looking into in the near future. How we develop our priority and projects reports is on an annual basis. We receive feedback from the community asking us to look at certain aspects, and then topics are proposed by the council members, and each year they're voted on by the council members. And we're a small organization, as I mentioned, the smallest federal independent agency that there is, and therefore our resources are limited as well. And so while we want to tackle on an annual basis a number of different things, we really have to prioritize and limit what we're able to do.
Mm-hmm. Understandable. And then, especially given the diversity of disability, there's just so many different aspects of things that need to be addressed. And I think even myself, the internalized ableism that I have, there are many things that I don't understand about the experiences of other people with different kinds of disabilities and health conditions. And so I really appreciate kind of the different lens that you bring to things, and particularly the bioethics side for individuals with intellectual and developmental disabilities. I think we have time for one more question. Let's see. Do you think that there will ever be a day when federal policy protects the healthcare of those of us with disabilities and does not penalize us who want to try to work and also have healthcare? That's related to the loss of SSI and SSDI when going above a certain income level.
Look, the answer is yes, and that's really why I accepted the position on the council, is that because I believe that it has to change, and right now we have, I think, the right federal partners to make a significant difference. That may change, right? Because elections matter, but given the time that we have, we're moving at full force to make sure that there is change, that we're just not simply talking about these problems over and over and over again. So I'm determined that there will be change here. So.
Fantastic. Thank you so much again for that fantastic presentation and this discussion, and for participating in our breakout sessions that are coming up.